Hello and welcome to the Voice of the Patient podcast. We are the podcast working to change lives, that is, improve the quality of life through not only hearing, but truly listening to the voice of the patient.
Hello, everyone. Thank you for tuning in to the Voice of the Patient podcast. I'm Zach Stearns, your host for this episode, and today our guest is Dr. Emil Berengut. Dr. Berengut is the Outpatient Therapy Supervisor at a tertiary cancer center in New York City, where he specializes in cancer rehabilitation. Dr. Berengut received his Master of Social Work from the University of Maryland School of Social Work and his Doctorate of Physical Therapy from New York University. After NYU, he completed the Hospital for Special Surgery Orthopedic Physical Therapy Residency program and became board certified in Orthopedic Physical Therapy. Dr. Berengut co-authored a monograph on osteoarthritis for the Orthopedic Section of the APTA, and he serves as a manuscript reviewer for supportive care in cancer. He has presented nationally on Cancer Rehabilitation and Orthopedics for the American Congress of Rehabilitation Medicine, the APTA Combined Sections Meeting, and the MSKCC Annual Cancer Rehabilitation Symposium. He has also lectured on orthopedic rehabilitation and psychosocial interventions at the NYU and Hunter College DPT programs. Currently, he serves as a mentor for an Oncology Physical Therapy residency program as well. Dr. Berengut, thank you for joining me.
Hi, Zach. Thank you very much for having me on.
Absolutely. So I found out about Dr. Berengut through social media. Now, Dr. Berengut, I've seen you active on Facebook and Twitter, and I found out that you are a physical therapist in oncology and a social worker.
That's correct. Yeah.
After finding that out, I just knew that you must have some incredible experiences and perspective to help us listen to the voice of the patient.
Thanks. I hope so.
Yeah, I'm sure you do. So we'd like to dive into that a little bit. So first, let's go back in time for a minute. What was it that led you to pursue a profession in healthcare?
I come from a family of physicians, actually. My grandparents were physicians. My parents were physicians. So I think I just grew up around a culture of trying to help people, around my father sort of talking about interesting diagnoses he's encountered, and interesting people he's had an opportunity to help. And my mother was involved more on the research side in medicine as well. So it's just something I grew up with. And at some point in my, college career, I just decided that this is what I'm interested in.
Awesome. So I relate with that, and I had not known that about you, but my father's a physician as well, and my mom is an ICU nurse. Oh, wow. So I think it's funny, and I totally relate with you on that, with wanting to go into medicine. It's something you grow up with, and for me, and I imagine for you, just from a young age, it's sort of taught to want to help people.
Yeah, agreed. I mean, for me, it was, I remember being a little kid, and my friends and that I used to play with, they would call me doctor. So I just never really considered being anything else. Some people grow up wanting to be an astronaut or engineer. That just wasn't an option for me.
That's so funny. My dad, actually, he loves to tell this story of when I was little. I was probably 3 or 4 years old. I remember it a little bit, but barely. And I would go into the hospital with him when he would go on rounds, and I would have this little toy doctor bag that had little toy stethoscope and other tools. I can't even remember what was in it. And I would go around saying, "We are two doctors," and everyone loved that. But on one hand, you're a social worker and a physical therapist rather than a physician. So could you talk about what led you into that certain area of healthcare?
Well, originally what happened was my mother was a psychiatrist. Through sort of exposure to her work, I became interested in psychiatry, mental health. I ended up working at an inpatient psychiatric facility in Baltimore, and this was in early to mid 90s. And from there, the natural sort of progression was to pretty much go into, I wanted to be a psychotherapist. And the fastest route to become licensed at that time was to become a licensed social worker.
Yep.
I worked in psychiatry as a counselor, as a drug counselor, various sort of held various positions. And eventually I went to social work school at University of Maryland. And from there, I again continued to work in addictions. Then I switched to working in employee assistance programs. And when I finished working as a social worker specifically, I finished working for an employee assistance program.
Okay. Well, that's great. Could you talk a little bit about what you did in that employee assistance program?
An employee assistance program were programs originally designed by the federal government to assist employees in basically handling stress and improving their performance at work. If you remember, back in the 80s, there was a slew of workplace violence incidents, primarily involving like the postal office, etc. And in response to that, the federal government helped to kind of design these programs, which, unlike your regular psychotherapy programs, which at the time were tended to be long-term, tended to involve insurance or for pay, these programs were designed to be sponsored by the workplace. In other words, they were not. There was no out-of-pocket cost for the employee. They tended to focus on short-term interventions, and also there was an element of providing interventions to the workplace as a whole. So, for example, providing debriefing classes, stress management classes. I remember I was working in employee assistance during 9/11, and a lot of what we did at the time was this sort of mix of individual counseling sessions as well as debriefing a lot of the workplaces. This was in the DC area. A lot of the workplaces that were affected by what happened, as well as employees who were potentially concerned about being deployed into the armed services.
Wow, that's really amazing, and I can tell you that I'm sure all of our listeners as well as I definitely appreciate that work that you did. Now that's amazing, and it sounds really challenging and rewarding too to me. And then you went into PT school.
I think there was a combination of personal factors, probably starting with the fact that I began to work in chronic mental health and addictions at a very young age. At age 20, this was in Baltimore, Maryland, at the time in throes of a very significant drug epidemic. There were just things that I was exposed to at the time that perhaps left me a little burned out.
Right.
And by the time I finished social work school, I just felt like there was really nothing in the profession for me left that I would like to pursue. There's also this sense of often it's very tough to calculate your impact and your work in social work because it just seems like it's very tough to measure how much you've assisted someone. And what attracted me to physical therapy was both, one, I had got involved in sports and martial arts at that time, and I kept getting injured. And my physical therapist seemed extremely satisfied and happy with his job. And what I really appreciated was that, he could either make me jump without pain or he couldn't. There was a way to track progress in a very objective way.
Sure. Absolutely. I relate with that a lot, actually. Some listeners may be aware that I actually was in a PhD program for clinical psychology, not for very long, but what you're saying really I relate with too, that it's hard sometimes to measure progress. Sometimes it's hard to know that you're doing anything in the area of mental health counseling. And so I felt that too, but I still really value that time that I had in clinical psychology in that program, and also just my background in psychology. And I'm from just following you on social media, seeing what you write, I can tell that you also value that history that you've had, that experience that you've had. So how has that background informed your treatment approach as a physical therapist?
It's been a very interesting growth process for myself. And I'm actually quite enjoying it as well, because like most of us in physical therapy, we start out in a very heavily biomechanical sort of anatomical model. Mm-hmm. And we often strive to perfect our skills in either, manual therapy or exercise prescription. And the more, and I really kind of threw myself into that field, I really dedicated myself in becoming as good of a sort of biomechanical therapist as I could possibly be. And then the more I started to practice, the more I started to realize that a lot of the reasons why I wasn't successful with some patients had nothing to do with the exercise prescription or the manual intervention that I had administered. Mm. And it had to do with perhaps the mood they were in, or the fact that they had to, travel 2 hours to get to the physical therapy clinic, or the fact that they haven't slept all night because they're taking care of their elderly mom.
Right.
And so little by little, I started to become aware of just how much these other non-physical factors, non-physiologic factors are impacting both the symptoms that my patients were experiencing and also my ability to effectively help them.
Right. That's awesome. And I relate with that and completely, because going into physical therapy school, you go through learning anatomy, you go through learning all of the physical things. And fortunately, in my program, we were exposed to the biopsychosocial model. And then going on out into internships, we see so many people who may have completely normal imaging, normal MRI, normal X-ray, and yet there's pain there. And so that really asks a question of what leads to pain, and what does that mean for us as therapists? It sounds like you've had similar experiences.
Yeah, the interesting thing has been that my experience working in cancer rehabilitation has sort of further developed and I think enhanced my understanding of how people perceive pain and how much their expectations and their environment really influences how pain is felt, mm-hmm. and how they report it and how much it impacts their function. And when I say enhanced, that by no means am I implying that I've discovered the truth. Yeah. But I've become, I guess, even more acutely aware of all those questions that I previously experienced. My previous experience was at a very strictly orthopedic surgery center. Mm-hmm. That is pretty much all they did. It's one of the sort of busiest orthopedic hospitals in the country.
Right.
And so as a result, I've had an opportunity to work with very, very talented, well-known surgeons, physiatrists, physical therapists, occupational therapists. And the surgeons would do these outstanding surgeries, just really world-class. And yet, as you said, the patients would continue to experience discomfort and pain and limitations in their function. Mm-hmm. And so this made me wonder, well, if the offending, so to say, body part is often cut out of the body, or if this segment is fused and is no longer moving, why is it that the patient is still experiencing pain?
Exactly.
And I just continued to ask these questions, and I'm continuing to do this even now. And I just started to think and kind of do a, analysis, sort of a case series in my head
Mm-hmm.
as to which patients tended to do better than others. And what I became aware of is it was the patients with lots of family support, patients who had access to very good medical care, patients who sort of had some internal factors, so to say, traits that made them more better able to cope with the discomfort of both, for example, surgery and whatever injury they may have experienced. Those tended to do the best. And that's not to say that there were patients who didn't have all those things who didn't do well, but I would just say it just seemed that they tended to have better outcomes overall as a group.
Sure. And there's a lot of research to suggest that is the case. There's been some with joint replacements. You'd mentioned that if you take out the offending anatomy and totally replace it, the prognosis should be pretty good. But it appears to be a relationship between some other factors, and pain catastrophizing, for example, that's one. And I could completely see how there is a strong effect of the social context of family support. And I can see how that could have a relationship with your expectations for recovery, with someone telling you, it's going to get better, it's going to be fine. And I think that could have a big effect on people.
And, the way I think about it is, it's maybe it's a weird analogy, but I think about it like sort of art and
Mm-hmm.
realist art versus like impressionist. And in a way, to really practice in a biopsychosocial model, because this is what I recognized about, let's say, and I'm not portraying myself as some art aficionado, right? But what I realized about like sort of Monet or Picasso was that they're very good artists. They can draw very well, and they can make something look very realistic. It's just that they had such an understanding of realism that then they can venture out into impressionism. And I think this is because what they're, like with Picasso, he picks up the cubes, and the Monet picks up the colors and the patterns. And what we sort of have to think about is that to really practice in a biopsychosocial model, you still have to be really good at anatomy. Mm-hmm. You have to be really good at all these other sort of more traditional approaches. It's just that you've got to see a bigger picture. Mm-hmm. And one cannot be a really good impressionist painter if they don't know how to draw a face, a regular,
Yeah, that's perfect.
This is what I tell my students. I'm like, listen, I still want you to know all these things in the body. You can't like flub anatomy. That's not like a thing for a physical therapist.
That's so true. I love that. And speaking to the art, it's so true that if you think of some, like, say Picasso is a great example. Van Gogh is also a great example. Where you might think, oh, Monet, definitely. You might think of them as their paintings as not really looking realistic, but you should look for some of their other drawings. You should look for some of their paintings and see how amazing they are, and really, then just sort of subverting it. But really, like you said, taking a bigger approach, that sometimes it's not so literal. That reality is not so literal sometimes. And that's I love the analogy of that to the biopsychosocial model. So I think that your experience in oncology is also very valuable, because pain with cancer can be very challenging to work with. Could you first talk about, to those who aren't experienced with what physical therapy and oncology entails, could you talk a little bit about that?
Well, just to kind of review some typical issues that we help patients with. So they're basically kind of four pain generating or function disabling mechanisms. There's cancer itself, there's surgery to treat cancer, radiation to treat cancer, and chemotherapy. Each one of the four tend to cause a number of impairments, pain being one of them. And they tend to cause it in very, I would say, specific ways. For example, with chemotherapy, there's often neuropathy, so chemotherapy-induced neuropathy. With post-surgical pain, there might be just regular kind of post-surgical pain. With radiation, you may have different kinds of nerve damage as well as burns to the soft tissue. And then sometimes the cancer, the tumor may grow in such an area as to cause a lot of pain, for example, in the bone. And so we primarily in cancer rehabilitation deal with I would say, for lack of a better word, the aftermath of these four pain-causing, pain-generating events.
Mm-hmm. That's really great information. Great to know. To me, it's always good to review that if someone has cancer and has pain, that there are so many different factors that can lead to that pain coming on. It's not just the cancer itself, but also the treatments for cancer as well. So, could you talk about what you've learned about your patients regarding coping with cancer diagnosis?
Wow, I'm still learning.
Yes, sure.
I've just had an opportunity I feel very fortunate, very blessed to be able to help my patients. I feel very privileged to be trusted with helping them move a little better and try to get back to their life as much as possible following this diagnosis. It's sort of the big C, right? It can be a very devastating diagnosis. Mm-hmm. And the amazing thing is just the resilience that my patients demonstrate. And I have seen and I've worked with patients who just have such an ability to see the positive in almost everything, in any kind of negative news they may receive. One of the advantages in working as a therapist in this population is that we have a full sort of 45 minutes, a couple of times a week mm-hmm. to interact with our patients. And we have this opportunity to establish relationships. And I've just been so amazed by just how strong my patients are and how they're able to, take these news that they may receive in terms of their treatment or their the outcomes and the results and still see positives.
Right.
And really appreciate every single day. And often my patients tell me, they say, I am just very thankful that I'm still here. I was told maybe I wouldn't be here at this point, but I'm going to make the best of it. The very fact that they're in physical therapy implies that regardless of the diagnosis, they still want to maximize their function. They still want to walk better. They want to pick up their grandchildren from the floor. They want to go out to a restaurant and or just get dressed.
Right.
And I really appreciate the opportunity to be able to help them with that. And something else to mention, I have many patients who have no evidence of disease for whom the cancer is it can be a far memory, and they maybe, for example, are training for a marathon, or they want to, go to the gym all the time. And so for them, it's something they dealt with maybe a few years ago, and now they're in a kind of a survivorship program. And so we're able to assist them in not only getting back to their activities of daily living, but actually to perform better in, for example, a sporting event or their job.
Well, that's awesome. My mother actually is a cancer survivor. She had Hodgkin's lymphoma, and it's something that I think about because every so often, and I was so little when she had it, I barely remember it. I remember seeing like marks on her back or something. It had to do with some procedure, and I just barely remember it. And she thinks about it a little bit in fear of maybe something coming back. And so I can't help but sometimes, share that fear of it. Do you experience anything like that when you're working with your patients?
It's interesting because this actually makes me think of another kind of question that came up in my own mind when I first learned about pain science and therapeutic neuroscience education and those other sort of not less biomechanical ways of managing pain. And I had initially become very interested in this idea that perhaps there's little physiologic cause for pain. And this idea that scans are often not very useful. But then when I started to work in cancer rehab, I became acutely aware of the limitation of that hypothesis in the cancer population, because scans are very useful. And a lot of my patients, when they experience pain, they share just what you said, which is, I'm afraid that the cancer is coming back.
Right.
And we're not in an environment where we can say, oh, the MRIs are often wrong and the X-rays don't show much of anything, because for a significant number of my patients, the MRIs are right and the X-rays are necessary. And so we have to sort of design a paradigm or a different framework within which to use some of the ideas from pain science education, as well as some ideas from a more strictly biomechanical approach, because we just can't afford to discount just how useful some imaging is.
Right. Yeah, imaging. The question of imaging is really big. And I imagine with cancer, I can see how it'd be so complex. And I remember in class, we talked about imaging and also just screening. And one might think that screening is crucial no matter what, that we should always be screening for everything, that we should always try to do every test that we can to figure out if we have some sort of disease or illness or condition, because then we can have some way of treating that early on. One issue, though, is what if it's a condition that you can't really treat or can't cure, or can't even, maybe in some cases can't even slow the progression of it. And really what that may end up doing is robbing you of happy years. So in a way, I can see in some cases it could cause harm. Now, I don't want to say that imaging is bad. Imaging is really important and crucial. But there are trade-offs. Have you had any experience with that situation?
Yeah, of course. I mean, I've had, whether in my sort of current setting or in the very strictly orthopedic setting, I've definitely had patients receive imaging results and come into my office and say, I'm told I have degenerated discs, or my back is shot, or my knee is gone, bone on bone, and it becomes often a self-fulfilling prophecy. Interestingly, through just involvement in kind of sports and even folks I work with, for folks I work out with, I should say. But sometimes it seems like work. They often kind of pull me up on the side. They're like, hey, listen, I kind of hurt my shoulder, and I was told, I went to see a ortho surgeon, and they said, I tore this, I tore that, or my meniscus is torn. And they often ask me for my opinion on whether they should have surgery or, what sort of their outcome, how long they're mostly interested in how long they're typically out of kind of rotation, out of competition.
Right.
And it's a very tricky situation because as physical therapists, many of us find ourselves in this position of we almost have to interpret another profession's diagnosis. Mm-hmm. And it's tough when your surgeon tells you one thing. It's tough to be the one to say, there's really not a lot of evidence to support, sort of meniscus surgeries for these kind of cases. Mm-hmm. And it's tough to say that there's really nothing to support knee scopes in general as a diagnostic tool in sort of straightforward sports injuries. Often I remember this one time one of my friends, he's a lifelong martial artist, very tough guy. He's has worked in various kind of armed forces, not for United States, but for other places. And he had a number of shoulder injuries. A younger guy, he's in his early 40s. And I know he had a rotator cuff repair, which failed. And he came to me and he said, I had a revision of the rotator cuff repair. I said, okay. And then I kind of didn't see him for a while. And he said, I ran into him on the street and he said, I just went to see my surgeon and, I'm scheduled tomorrow to have a shoulder replacement. I said, a shoulder replacement? What do you mean? He said, yeah, I was told it's bone on bone in my shoulder and my shoulder really hurts. And I said, does your surgeon know what you do? He said, yeah, he knows, he said it'll be okay. I said, your surgeon told you it'll be okay you're going to be able to play sports and play kind of contact sports with a replaced shoulder at age 40?
Wow.
So I said, and again, I'm just interpreting kind of what he told me, right? This is third person. I don't actually know what the surgeon said to him.
Right.
So I said, listen, do me a favor. I know what you want to do in terms of your, leisure activities, so to say, and professional activity. Go talk to someone else and just see if this is really the only thing that, that's left for you. Mm-hmm. So, and this was like a few years back, he went and he never had that shoulder replacement.
Wow.
And as far as I can tell, he seems to be doing okay. He moved to another country, so I'm not sure how much he's, I definitely know he's still involved in martial arts, mm-hmm. but he was able to succeed without that. And I feel really good about that.
Sure.
I didn't tell him, hey, listen, your surgeon is wrong and
right.
they don't know what they're talking about. I gave him my opinion as it relates to a particular sport. I gave him my opinion as a physical therapist and as a friend who kind of knows him.
Right. That's awesome. And it's really important to emphasize that, there's nothing against the surgery, nothing against the surgeon, but was that appropriate for that person? Was that in the most appropriate way of treatment in order for that person to meet their goals and to be able to do what they want to do? It reminds me actually of my mom again, which is weird. I did not plan on mentioning my mom at all in this episode. And I think this is the third time. She actually, one time she fell and she fractured her humerus. So she had a hemi shoulder replacement. And later, after going through rehab and everything was supposed to be fine, she went back to her surgeon and said, you know what? I can't lift my arm straight up in the air. In other words, she couldn't abduct 180 degrees. She can lift it all the way up. Mm-hmm. And she told me his response was, why would you want to do that? And so I think that's amazing. I just think it's amazing because, again, like in her case, it was a necessary surgery, but she wasn't really fully informed of what recovery would be like and what the actual outcome would be. And I think that we really owe it to people to make sure that there's complete informed consent of what will happen from treatment. And going back to your experience in oncology, really making sure that people's voices are heard, making sure that they are fully informed, I could see being so crucial. Really, in that situation, working through a diagnosis of cancer, trying to improve function despite it. I can see how many patients really just want a provider who will listen and will care. So could you talk about how your quote unquote soft skills have developed over your career?
It's obviously it's an ongoing process,
Sure.
and my best teachers have been my patients. The interesting thing was going back to my experience when I just become a physical therapist, and I had, I think as many of us kind of have these ideas about these fancy exercises, often involving kind of standing on one leg on a BOSU with, various rubber bands attached. And I remember working with just outstanding physical therapists, and I noticed they didn't really do any of those so-called functional or fancy exercises. They stuck to their basics, and if the amount of, chocolate one gets from thankful patients as an indicator, their patients were extremely happy.
Yes.
And they did really well. They moved well. And I was like, what, why aren't they doing this, this amazing manipulation I just learned at a course? Why aren't they standing on, one leg while doing, while holding a barbell or a kettlebell in their left hand?
Yeah.
And what I realized was it's their ability to connect with the patients, to establish therapeutic alliance. And one way I sort of tell my students is they receive a mandate from their patients. And once you receive a mandate from your patients, your outcomes become so much better. And that's not to say that there's not a patient that may not need that manipulation or may not need to stand on a BOSU ball or whatever. But the most important factor, I think, in being a successful healthcare provider, I would say across any discipline, is the ability to establish that alliance with a patient. And there's data that shows that your outcomes are dependent on therapeutic alliance. They've actually been able to quantify it. So when I've noticed that, when I made that connection, I realized that it's a skill that I've worked on previously in my previous career as a social worker. And this is something that I began to enhance and notice. I began to notice how I approach patients, what words I use, how do I encourage them, what is the message that I tell them about my skills, my ability to help them, about their expected outcomes, and how can I enhance it. Now, it's just like any other sort of field, especially any other helping profession. There are some patients who they just want to come in and they want you to show them those exercises, or they want you to put hands on and just make them feel better, and they're not really interested in giving you any mandates or establishing any alliances.
Right.
And my job is to recognize when that's the case and not try to force sort of my preferred approach onto someone else.
Right.
So it's a work in progress. I encourage all of my students to develop that part. I'm very happy to hear that you guys were exposed to that in school. I think, and I hope that's a new trend in physical therapist education. And that's an area that I feel can just continue to grow in our professional education as well as our continuing education.
Sure, I totally hope so too. I hope that it is a trend more than an outlier. And I also want to go back to another question about pain, and that is also with your experience in oncology. What is your approach to treating pain, and how does your approach to treating persistent pain differ when it is cancer related?
I don't know. I don't know how different it would be from other sort of patient populations, but I think focusing on two things, which is one, finding out exactly what is important to the patient. Why are they there? In social work, there's this concept of, we were taught, always meet the patient where they're at. And two, establishing a contract and being honest in my ability to sort of effectuate their goals and making the contract as relevant to them as possible. And in many cases, as much as sort of I hate to admit it, the pain does not change, particularly when it's cancer pain or pain that has been in place for many, many years. What does change is the function. And this is where physical therapists, I think, really shine, is understanding what is it, how does this pain limit the patient's ability to interact with their environment? And what can we do to make it as manageable as possible? And this can range from anywhere from finding, postures and movements that may be less painful. It may be teaching pacing and sort of taking breaks. It may be using assistive devices. It may be educating them about where and how this pain is sort of coming from. And it may be strengthening them and making them more able to sort of go up steps, walk a little farther, get dressed easier. So it's a full range of techniques and interventions. I think that the challenge is recognizing exactly what we can and cannot do. And there are some folks for whom physical therapy at that moment may not be the best thing. And, if someone is coming in with, 10 out of 10 pain, and this pain is cancer related, then they really ought to be evaluated by a physician and have their pain managed a little bit, right, more prior to starting a kind of any sort of rehabilitation process.
Absolutely.
And for me, and I think for some other folks, the challenge is recognizing if this is the right moment in time to be able to provide physical therapy. And for some folks, a small number, but a significant number, this may not always be the right thing at the right time.
Well, that's great, and thank you very much for that information. It's really helpful, and particularly to me as a student, and to other students as well. Before we complete our conversation here, is there anything else you'd like any of your listeners to know, whether it's about working with people who recently received a cancer diagnosis, or anything else that we talked about?
I want to I have a message for students and new grads. And this message is that through your education, through continuing education, and through your DPT programs, you're going to be exposed to lots of very talented therapists who will teach you about methods that work for them. But what I encourage all of you is to keep an open mind and understand that often The methods that you are taught are effective because they fit some sort of niche within your instructor's experience, personality, and a skill set. And so as you take these courses, as you interact with some of the eminent folks in the field, keep that in mind. And you will find a method or a combination of methods that are going to be most effective based on your own personality, your own experience, your own patient population.
That's awesome. That's really great. And I think that's something that I think students and new grads really need to hear more, because I can tell you, and I feel this too, that going out into practice, you kind of feel like I need to learn so much more. I need to learn from people who know all the magic tricks, who know the most awesome techniques. And in reality, we need to find out what type of provider best fits us and also fits the patients who we see. And it sounds like awesome advice that you have for us. So we really thank you. Thank you so much, Dr. Berengut, for coming on to the show. How can our listeners contact you with any questions or feedback?
I am on Twitter at Emil Berengut, and I'm also on Medium, although that's not as updated. The last thing on there, I think, was my rant about cupping that I put up during the Olympics.
That never gets old, though.
Yeah, never gets old, right? But yeah, those will be the good ways. Those will be the best ways to kind of reach out and get in contact.
Awesome. Well, that concludes our episode. To our listeners, if you enjoyed this episode, or if you have a story to tell as a patient, a provider, or both, then please let us know. Find me on Twitter at Zach R. Stearns or Dave Reed at DReedPT. Thank you so much for listening, and keep listening to the voice of the patient.
If you enjoyed this episode, go to thevoiceofthepatient.org, where you can find other helpful podcasts and blog posts that will show you how to improve healthcare through not only hearing, but truly listening to the voice of the patient. Thanks for listening. This podcast is brought to you in partnership with the Senior Rehab Project at seniorrehabproject.com.